Welcome to episode 2, or rather part 2 of episode 1 of The Animal Heartbeat, a podcast on veterinary cardiology, hosted by him, Jose Novo Matos, and me, Kieran and Jose, both of us cardiology specialists, both of us budding podcast enthusiasts. If you're interested in veterinary cardiology, this is the place for you. So our first episode on feline cardiology ran a bit long. We've got a lot to discuss. So what we have done is separate this into a second episode, focusing on apparently healthy cats with heart disease, thinking about echocardiographic findings and what they might mean for the cat. Obviously, we've talked about echo, and you know, I don't think it's really the focus of the conversation today to talk about the different phenotypes that we have, the sort of HCM, RCM, DCM phenotypes. But I think it's worth saying, talking a little bit about HCM and about left ventricular hypertrophy, because it's just so common to find it in these cats that we're echoing with incidental murmurs or suspected cardiovascular signs, that I think it's worth focusing on. And obviously, when we talk about a hypertrophic phenotype, what we mean is that the left ventricular wall thickness is increased. What's your perspective, Jose, on hypertrophy in cats? So it is all hypertrophy that we see on an echo. Is that all HCM? Are there different causes of that we might expect and that we might need to think about ruling out in these cases?
Exactly. That's an important topic. And that just stresses how interesting HCM is. Because you see, if you have just the disease is already challenging to diagnose per se, and then there are disease mimickers, HCM mimickers, diseases that mimic HCM. That's why it's way more interesting than boring mitral valve disease. Because you scan, there's mitral valve insufficiency, great. Okay, you can come up with some fancy echo stuff, but that's it. Not with HCM. So
I'm just going to step in to rescue the reputation of a future podcast episode where mitral valve disease is going to be a fascinating topic. But maybe we can edit this bit out. But I think feline cardiomyopathy definitely poses more challenges and more food for thought in terms of what our diagnosis is and what our prognostic indicators are compared to mitral valve disease. I completely agree with you about that.
Yeah. But as you were saying, it's really important. So when we echo a cat, or we read the echo report and we see that there is left ventricular thickening, thick left ventricular walls, we should not call that straight away HCM. A nice approach that the most recent ACVM guidelines have taken, mimicking the European Society of Cardiology approach to classify cardiomyopathies, is to define the echocardiographic findings as phenotypes. So that means we scan a cat and we detect thick left ventricular walls. So we'll call it HCM phenotype. This means that this heart looks like HCM. We are not saying that this cat has hypertrophic cardiomyopathy, familial genetic hypertrophic cardiomyopathy.
And that's an important distinction, isn't it?
Exactly. And all we are saying, it looks like HCM. And this helps also to discuss the case with colleagues and clients. People understand, okay, this looks like HCM, meaning the walls are thick. Great. And then we need to stop and step back and think, okay, what are the causes of increased wall thickness? And the low-hanging fruit will be increased afterload. Systemic hypertension will cause left ventricular hypertrophy. So we should measure blood pressure in these cats to exclude systemic hypertension. Of course, measure blood pressure in cats is very challenging and so on, maybe a bit beyond what we are discussing here today to discuss how to measure blood pressure, but it's really important to exclude systemic hypertension. The next common or potentially important cause of left ventricular hypertrophy is hyperthyroidism. So hyperthyroidism can cause left ventricular hypertrophy. And these two conditions are really important because they affect the same age group as cats with familial HCM, as we were saying earlier on this episode. So HCM, familial HCM, has something called an age-dependent penetrance. Is more likely that cats would develop the phenotype as they get older. And again, also the same happens with hyperthyroidism or systemic hypertension, affects mainly middle-aged older cats. And so this means that then we have three conditions that affect elderly cats or middle-aged cats, and we need to exclude those once we detect hypertrophy, especially because systemic hypertension and hyperthyroidism are easily treatable conditions, which HCM, unfortunately, is not. There is not a specific treatment for HCM. So it's really important to, first of all, detect those conditions or try to exclude them because they may mimic HCM. So those are the two first differential diagnoses that we should all have and exclude. I just wanted to say before we discuss further phenocopies or HCM mimickers. Of course, the challenging is that a cat may have HCM and systemic hypertension, or may have HCM and hyperthyroidism. Because if we have just said that these conditions are so prevalent in elderly cats, the cats will not just choose to have one or the other. So it's likely that cats may be affected by both. And that's okay. And you may, with more experience already on echo, have a high suspicion that this cannot be only systemic hypertension or only hyperthyroidism. And the walls look thick, asymmetric, very heterogeneous. Different segments are affected by hypertrophy. But nevertheless, if a cat has hyperthyroidism or systemic hypertension, we will need to treat those because that will affect afterload, will affect cardiac remodeling. And so hopefully, even if there is a background, if the cat has HCM on the background, by treating those two conditions will help to have some degree of reverse remodeling. So those conditions are really important to detect and treat when present.
I remember one very, very sort of memorable case from my residency where it was a cat that had come for radioactive iodine treatment for its severely uncontrolled hypothyroidism, and he presented in heart failure. So he had huge left atrial dilation, and his heart rate was consistently incredibly high, really massive hypertrophic phenotype on the echo. So we gave diuretics, we treated the heart failure, we started clopidogrel, for his ATE risk. So all these things that I think we're pretty comfortable doing. And then we treated his thyroid disease medically. So we basically started him on some topical methimazole, I think. My medicine on thyroid disease is a little rusty. And he hugely improved. Whether he was just grooming that off and eating it or it was working transdermally, I don't know. And then actually he stabilized quite well with that. But radioactive iodine is the best treatment for those cats. And we decided that, okay, with radioactive iodine, are we going to put him in isolation for 3 weeks because we can't handle him for health and safety reasons and risk that he's going to go into heart failure, after his sedation for his injection? Or are we going to accept that his thyroid disease may or may not be perfectly controlled and that will impact his welfare in many ways, one of which is it'll make his heart failure worse because of the volume loading effect and the cardiovascular effects of the disease? So the owners decided that they wanted to go down the road of let's try and treat definitively. At least then we get rid of the thyroid from the equation in most cases with radioactive iodine, and we'll see what's left with the heart. And they were not too risk averse. They were comfortable with that. And he was taking oral medication very reliably in food. And that's really important for those cats. So he was sedated with that combination we talked about before. He had his radioactive iodine injection. He went into isolation. Did fine. Respiratory rate was fine. Took his meds, behaved himself. Everything great. And we echoed him just before he went home. We had a quick sort of peek and shriek look. Actually, his left atrium looked all right. It had come down in size. We were quite impressed with that. So we saw him back 3 months down the line to see what his heart was looking like. Euthyroid, doing brilliantly. Still on diuretics, but quite a low dose. And on his echo, his left atrium was a normal size. It was measuring 15.5 millimeters or 16 millimeters in long axis, which is great. That's top end of normal. I'm happy with that. His left ventricle was a real mess. It was still hypertrophic, huge papillary muscles, end-systolic cavity obliteration, outflow tract obstruction. There's no doubt he had this typical hypertrophic or HCM phenotype. These sort of other echo features of HCM were there too. But his atrium was a normal size. So we weaned out his diuretics and stopped them completely. So he came off his diuretics. He still had HCM. But the thyroid disease was what had tipped him into heart failure. That's what had shortened his life expectancy and given him those negative prognostic indicators. So we'd aggressively managed the thyroid disease. We'd taken that risk. It was a bit of a roll of the dice, but it was absolutely the right thing to do for that cat. So for me, heart failure is not an exclusion for radioactive iodine treatment or trying to treat. so long as all parties, the owners, the vet, everybody knows that, maybe it doesn't go that way. Maybe they are too far gone, and maybe the risk is a little bit higher than we'd like it to be. But that case really emphasized to me the importance of try, because actually he did great. And that was a big lesson learned for me, I think. What's your age where you start thinking about, okay, this cat's got a murmur, I've echoed it, it's got HCM or an HCM phenotype, I'm sorry. When do you start thinking, okay, this cat's, I don't know, 5? Do you measure BP, worried about systemic hypertension in those cases? Do you run a thyroid panel in those guys? How do you approach that? Do you have any sort of cutoff values, or do you just test every cat with an HCM phenotype?
Exactly. No, we generally use a cutoff of 6 years of age, because that's what the guidelines have suggested, and also looking at the feline cardiomyopathy guidelines, and also looking at ACVM systemic hypertension guidelines. That sounds a reasonable cutoff. But that's what generally we do. But again, we are not very religious about it. I think it would be fine if someone would say, well, I would like to measure it before a bit younger or a bit older. What I think is really important about that is we diagnose now systemic hypertension and hyperthyroidism at the very early stage in comparison, we vets, in comparison what we did 20, 25 years ago.
If you look at all the Phil Fox research from 1990, 1993, that sort of era, that it's very different, isn't it? The cats who were presenting hyperthyroid were way more advanced than they are now, which is great.
Exactly. Yeah, exactly. So that's why also we will not see like classic cases where hyperthyroidism has caused very, very thick walls, or systemic hypertensive cats who have very, very thick walls just caused by those two conditions. But so having said that, but as this disease may markedly affect LV morphology, especially in a cat that might have HCM already, I think it's really important that we try to detect them as soon as possible, as early as possible, and try to address them. So 6 years of age, but to answer your question, 6 years of age is generally our cutoff. And again, just as we are talking about these, just to remind everyone that blood pressure, systemic hypertension is very challenging to diagnose in cats, because we have just mentioned before how stressed, anxious they are in the clinic and so on. So to diagnose, we need to be careful and not overdiagnose systemic hypertension. Having said that, we need to take serious any high blood pressure measurement we have in a cat. I think the ACVM guidelines on blood pressure, systemic hypertension in cats, published at JVM, are very nicely written and they suggest a very nice protocol on how to address cats with high blood pressure, different cutoffs, depending on how worried we are about end organ damage. I think I would recommend everyone to read those guidelines and follow their recommendations, but just remember that we need to be careful in one hand, because we may have something called white coat effect or stress situational hypertension, which may mimic systemic hypertension. But on the other side of the spectrum, we should not underestimate high blood pressures in cats. But I look at those guidelines because they are very nicely written and give very nice practical tips on how to approach these cases.
And one thing that I quite like doing in those cats is actually a fundic exam. So looking at the retinas. I'm not going to pretend I'm great at it, but I think just to get an idea of, does it look like, if we've got some hypertrophy on the echo, we've got a BP of, I don't know, 195. I think if it's 230, all right, I think we probably believe it's real. I'm not sure white coat, or in my case, blue scrub top hypertension goes that high, although maybe it does. So I'm still a bit wary. But I think if it's 195, 200, I really want to get a fundic exam on those patients. I don't necessarily dilate the pupil. I think the cat doesn't love that, and I'm not the best at fundic exam. But if an ophthalmologist probably will want to do that, and if you've got time and a bit more expertise, maybe you do want to do that. But I quite like just to have a look to see are the blood vessels tortuous looking? Is there any hemorrhage, any sort of punctate detachment or anything? Where you won't see it grossly looking at the eye, like these terrible hypertension cases. I've got full retinal detachment and uveitis and things. But just these more subtle changes that even a novice like me at fundic exam can identify. So that would help swing my decision. Do I treat now, or do I get the primary vets to remeasure that, or do I remeasure that myself in a few weeks? Maybe with some gabapentin on board. bring them straight from the car straight to the consult room, no sitting in the waiting room, no winding up and getting a BP then. And I think that can be very helpful. So you mentioned about the sort of hypertrophic phenotype, and ruling out other differentials for that. Obviously, if we do have systemic hypertension or hypothyroidism, it's something where we can try and get on top of those diseases. We can reassess the heart. Are there any patterns of cardiomyopathy in cats where you identify it and you say, actually, this is benign, or this is something that I'm not worried about? Do we see different prognoses for different patterns of hypertrophy or different echo changes?
So that's a big area, something that hopefully we will learn much more in the next 10 years or so, I hope. That's an area that I like very much, and I'm sure many other centers are working on that, which are patterns of hypertrophy, as you were saying, and also other diseases that may mimic HCM and may have a better or worse prognosis. Depending on the pattern of hypertrophy, if you look at the pattern of hypertrophy, a form that is generally considered to be more benign is when hypertrophy only affects the most basilar part of the septum. People have used different names to describe that basal bulge, basilar hypertrophy, both in human and veterinary medicine. I like acronyms. So DUST, I think, is a very cool acronym.
And I'm a massive fan of the Philip Pullman books, His Dark Materials. I don't know if you know them, but DUST is something that features highly in those. So I'm a huge fan of DUST as an acronym for discrete upper septal thickening.
Exactly, but exactly. So, but people can use, of course, can describe it differently. But so, for the ones that are not aware of this pattern of hypertrophy, is when the most basilar part of the septum is thick. This is a phenotype most commonly seen in elderly people, also believed to be most commonly seen in elderly cats. And there's only one study that has looked into outcome. Is in the form of an abstract, but has shown that the outcome in these cats is very, very good, and in humans it has an excellent prognosis. So when the hypertrophy is just very basilar, generally is associated with a good prognosis, and these cats do not go into congestive heart failure. There's a big debate on how to call this. Is this a mild form of hypertrophic cardiomyopathy, or is this just an age dependent change due to the angle between the septum and the aorta, the so-called aortoseptal angle?
It's something we see in those dogs, isn't it? With subaortic stenosis, we see changes in that region related to aortoseptal angle, and I think that's interesting. Is that happening? Are there genes out there that cats have which become active with age? That sort of give them the substrate for developing hypertrophy, and then cats who've got a little steep or acute aortoseptal angle, those guys are more likely to get some hypertrophy in that region, but they don't have other risk factors, and therefore they don't get what we would normally refer to as a sort of classic HCM phenotype or hypertrophic phenotype. I have to say, if you'd asked me 5 years ago, I would have said any hypertrophy is HCM. So I would have said, okay, you've got hypertrophy in the basilar septum. Yes, that is HCM. This is something we need to monitor. I would have classified it as I classify everything else. I would have said, anecdotally, in my experience and that of other cardiologists, we see that as a relatively benign pattern. But I wouldn't have called it something different. And I think actually using a separate descriptor for it, like DUST, or basilar bulge, or whatever you want to call it, rather than saying HCM, I think that changes how we think of it, and it communicates that it probably is something a bit different. So I think for me now, I'm a lot more relaxed in my conversation with an owner if I just see that discrete upper septal thickening than if I see discrete free wall thickening, for example, or massive papillary muscle hypertrophy. They're very different conversations I have with an owner, rightly or wrongly, because there isn't a consensus statement on this at the moment. There isn't, great long-term outcome data. But this is something that, with experience, I think I've triaged based on hypertrophy pattern. And these are the nuances, I think, of feline cardiology that we're all coming to understand, and maybe in 5 years' time, again, I'll listen back to this podcast and go, I did not know what I was talking about. I was so wrong about that. Yeah. It's an area of evolution, isn't it, in our understanding? And that's one of the neat things about veterinary cardiology, actually, generally, is there's a lot of active research and a lot of open-minded sort of discussion on these various topics. So I think with the discrete upper septal thickening, I'm fairly relaxed about those. Do you have any other advice for either primary care vets or anyone out there who wants to develop their feline cardiology experience? Any advice for prognostic indicators on echo, or generally any prognostic indicators that would help guide our conversations with owners, with carers of those cats diagnosed with a hypertrophic phenotype?
Just to say that we have just mentioned dust or basilar bulge, and in fact, that's one of the exceptions where we can say that a specific pattern of LV hypertrophy is probably benign. Okay. Because otherwise, the degree of hypertrophy has not been shown to be associated with prognosis, except in extreme cases. So Rosie Payne, again, while she was at the RVC, has shown that extreme hypertrophy, meaning wall thickness above 9 millimeters at 10 diastole, was associated with a low prognosis. But was not was not the factor, the variable that had a higher risk or odds ratios in comparison with other factors. So hypertrophy doesn't seem to matter that much.
And that's a bit of a misconception, isn't it, amongst practitioners? I have people say, the left atrium was normal size. Oh, but the free wall measured 9.5 millimeters or whatever. Or sorry, maybe that is an example of a prognostic indicator. People say, oh, it's very hypertrophic. But the left atrial size was normal. I'm really worried about this case. Think it's on the brink of heart failure. But obviously you or I would look at that and go, okay, well, let's come back to the left atrium, because that's going to be our barometer of risk in that particular patient. And we're less worried about the hypertrophy.
Exactly. So hypertrophy is important to document and define and diagnose the disease, but then hypertrophy per se would not tell us how likely is this case to develop complications. And it's just important to stress that hypertrophic cardiomyopathy, in fact, does not mean is not a bad disease all the time. And that's a really important concept to explain to clients. Similar to humans, in fact, the majority of cats with HCM would not suffer any complications. Several different studies have shown that around 30%, so 1/3 of cats, would develop serious life-threatening complications, such as congestive heart failure, aortic thromboembolism, or sudden cardiac death. Up to 70% of cats may remain asymptomatic. And that's important to explain to the clients when we detect hypertrophic cardiomyopathy. We're going to need to be more careful with these cats whenever they undergo general anesthesia, they need fluids and so on. But many cats will remain asymptomatic all their life. And that's important. And that brings the left atrium into equation, as you were saying. So the left atrium is really probably, to measure the left atrial size, is one of the most important measurements, variables to do on echo, because this would tell us if there is increased filling pressures and how high is the end diastolic pressure, and what's the risk for the cat developing congestive heart failure or ATE. So for any practitioner out there, I would try to get very good at measuring left atrial size and have a feeling of what is normal, moderate, or severe left atrial enlargement, even without measuring it. And so I think left atrial size is by far the most important echocardiographic variable in cats and probably also in dogs to assess what's the risk of complications associated with their heart disease. So just to repeat myself, I think first you want to diagnose the cardiac phenotype, and you may define, depending on what you find on the left ventricle wall thickness and systolic function and so on. But then what we really want to know is what is the left atrial size. So what we really want to know is this a stage pt2 cat, a cat with large left atrium? Because those are the cats that we truly want to identify. That's the red flag, left atrial enlargement, because we need to be careful with traveling in those cats, stress, IV fluids, general anesthesia, because these are the cats that may be pushed into congestive heart failure, and the clients and the vets need to know that they are a bit like a ticking bomb. They may at any moment decompensate. So left atrial size would be my number one risk factor, or left atrial dilation.
Yeah, it's definitely our sort of go-to. If we're unsure about anything, we always go back to the left atrial size. And I think that's a big deal, isn't it? So I think, there's so much to talk about in feline cardiology and cardiomyopathy that I think, it's a whole future podcast episode to talk about heart failure. And how to manage those cases that are either the highest risk or the history of heart failure. But I think just as a final word on the sort of preclinical cardiomyopathy and diagnostics and decision making in those preclinical cats, let's focus on when to treat with clopidogrel. Because the consensus statement from ACVIM, which is a fabulous document talking about the staging system, A, B, C, D, and B1, B2, B being preclinical, B1 being normal left atrial size or normal left atrial size or mild left atrial dilation, importantly. And stage B2, which is the cats where clopidogrel treatment is indicated because of a higher risk of ATE events. They are classified as moderate to severe left atrial dilation. You can see where I'm going with this question. What's your cutoff as a feline cardiology expert for moderate to severe left atrial dilation? Because the consensus panel didn't write a cutoff, probably because they couldn't agree, which is fine. But how do you interpret that?
Yeah, I guess one of their aims was also, as there is no data really showing what the cutoffs should be, and then qualitative assessment is incredibly important, and that's important also to anyone that is starting scanning, echoing cats. Maybe at the beginning, they should not be too worried about measurements, because every measurement is prone to error. And
I like that.
To have very good images and so on to measure it properly. So the qualitative, if it looks big, it's big. If the left atrial looks big, it's big. And that's when you should start treating. If it is like, you are not sure, it's probably not that big. So I think that was always, I think, the take-home message from the guidelines. But generally, clearly putting my neck out there, I use left atrial diameter, long axis diameter of more than 18 millimeters as moderate enlargement, and LAEO more than 1.8. Why I do that? Because I think sometimes left atrial diameters in normal cats may reach 17 millimeters. Depending if your image is not perfect, and you might be getting a bit of the left auricle. Mm-hmm. And LAEO between 1.6 and 1.8 is, to me, mild enlargement, and so that's why I generally use 1.8 and 18. What's your cutoff? Yeah,
it's interesting. I think I find that they can give me quite a different impression, those long axis left atrial diameter versus left atrium to aortic root ratio. And I always think that's because the left atrium aortic root ratio is a compound measurement and therefore is more prone to error. So if I'm in doubt, if I get an LAAO that looks normal, but I get a left atrial absolute diameter in long axis, maximum diameter of more than 16, I think I believe the long axis diameter. I agree with you. If you're slightly oblique and you're not sure sometimes, that you are, then you will overestimate that long axis diameter. So I think I agree. 18 millimeters plus is definitely abnormal. 16 millimeters I would call top normal, but I certainly wouldn't make any treatment decisions based on 16 or 17 millimeters diameter. And I think the advice I tend to give practitioners is actually really an LAAO of 1.75, which I guess is the same as yours, is 1.8, isn't it, if we round up? And so I think 1.8 is a good cutoff for the LAAO measurement. Long axis diameter, I have a harder time with deciding when to treat based on that. And actually, in my own cases, if it's not a sort of advice case from a general practice vet who's contacted me, if it's my own case, I really take account of left atrial function, and I looked at left atrial fractional shortening. So I think if I've got an LAO of 1.7 or 1.75, but my left atrial fractional shortening in M mode, in that same view as the LAO, is I guess 15%, less than 20, then that's a problem for me. I'm sorry if you hear a noise in the background. My dog has just joined me for the podcast recording. She's protesting against a topic of feline cardiology. The cat, being a cat, typically is absent. So Yeah. So do you measure the left atrial fractional shortening? Is that your approach?
Absolutely, all the time. We measure that as a default measurement now.
Yeah.
Very easy, very easy to do. Again, I don't think for people working more on left atrial systolic function, you may argue is not a great measurement of global left atrial function and so on, but it's very easy to acquire. And so it's something that we do all the time. And I totally agree with you. We look more into left atrial systolic function. And we also look into left atrial systolic function or fractional shortening to decide when to treat. And so that's important. I just wanted to, I'm not sure how much time we have left, but there was an HCM phenocopy that we did not mention yet.
And I feel wrong about having not mentioning this because it's a really important topic. Yeah, absolutely. You know what? Let's make time for it. We're our own masters, so let's discuss this because this is an important thing to think about.
So what we are saying here is, so when we were discussing HCM phenocopies, diseases that mimic HCM on echo, we mentioned systemic hypertension, blood pressure. And just please let me quickly add that acromegaly is also a differential diagnosis for HCM phenotype, especially if you have a diabetic cat. A dehydrated cat, the walls may look thick, which is called pseudohypertrophy. So those are other important differential diagnoses for
and of course congenital heart disease like subaortic stenosis, or these are all, it's all a hot topic, isn't it? Yeah,
absolutely. But then what we were mentioning too was a work that we collaborate, Kieran and I, with other cardiologists across the UK in Europe, where we describe a condition called transient myocardial thickening, which the name says it all, which are cats that are presented into congestive heart failure, cats that are presenting acute congestive heart failure that on echo, they look like HCM, the walls look thick. But then over time, the wall thickness may normalize, and they have reverse remodeling, and the heart may normalize and go back to normal. Hence the name transient myocardial thickening. It is a bit questionable what is the cause for this transient wall thickening. Certainly is a very acute process where the left myocardium is suddenly abnormal, and which cause the cats to develop congestive heart failure and over time may normalize. So the most likely causes for this condition are either acute myocarditis. So myocarditis in humans, acute myocarditis causes myocardial edema. And something that is really important to remember is when we echo a cat or dog and the walls are thick, this does not always mean hypertrophy, means increased thickening. Increased thickness. And so on echo, we cannot really differentiate between hypertrophy and myocardial thickening caused, for example, by myocardial edema. And so these cats most likely have some degree of myocardial edema plus minus inflammatory cell infiltration that cause the walls to look thick on echo, and then they normalize over time. So it could be acute myocarditis. What is funny about these cats is the majority of them before presentation had a stressful event, an antecedent stressful event, which can be a different sort of things. They may have undergone castration, standard surgery for castration, spaying, or more serious stuff like a road traffic accident, or they were just not well and they went to the vet, or the owner left them in a cat shelter for some time.
That's the one that I remember really well, because that was one of the cases I contributed. Was a cat whose owner, actually she was or is a vet, the owner of this cat. And she went away for the weekend, and the cat went to the cat shelter or the cattery, and that was enough of a stressful event to trigger this cataclysmic heart failure event.
So exactly. So antecedent stressful events were common in these population of cats, or are common triggers apparently of this condition. So one option is acute myocarditis. Cats suffer acute myocarditis, myocardial edema that pushes them into congestive heart failure. The other option is is something called stress cardiomyopathy. So in humans, there's a very important type of cardiomyopathy called Takotsubo cardiomyopathy or stress cardiomyopathy, where people that undergo severe physical or emotional stress may be pushed into congestive heart failure and may be affected by a type of cardiomyopathy called Takotsubo cardiomyopathy. So we're not sure yet in cats if it is more myocarditis or this stress cardiomyopathy, but that is really important, and we wanted really to stress that in this podcast on feline cardiomyopathies is that some cats may have a transient form of heart disease, and this seems to affect mainly young cats with a stressful event. Not every cat to be young or have a stressful event, but these are the two classic red flags. But what is really important, and we want to stress, is, to me, the take-home message is treat every cat with heart failure if you can, because it's very difficult to predict how will the cat respond to heart failure treatment. And some cats may have a transient form of heart disease, and in this case, every cardiac drug may be stopped later on, and the cats are back to normal. But even other cats may not have transient heart disease; they may still have HCM, but they may respond really well to heart failure. So do not quit on cats just because the heart looks horrible on echo, or their breathing is terrible and they look very, very poor, because the way they respond is completely unpredictable at baseline. So
yeah, I think I've given up giving people numbers. People want survival times, or they want to know what are the chances of survival. And I think it's important as the clinician that we have that conversation. We say, okay, well, we're worried about your cat for the following reasons, or we're not so worried. We think they'll respond well, or whatever. But I always stress to people, cats make it hard to give estimates. Because actually, I've, in the past, I used to use the word advanced heart failure. I don't use that in cats anymore, because that implies that they're on the brink of death. And I think the number of cases that you and I and innumerable cardiologists have seen where the heart looks awful on the echo, and you think, crikey, how is that cat upright and breathing, albeit breathing quickly? And then a year later, they come back in for a routine reevaluation. You think, oh my goodness, I thought you were gone. And here you are. This is fantastic. And I think, for me, one of the challenges with the transient myocardial thickening is those cats look so sick. Their heart failure is often terrible. They often present bradycardic, hypotensive, those real feline cardiogenic shock cases. And it's not uncommon in the past for us to have to treat them with things like dobutamine, infusions and really intensive therapy. But often what you find with them is you're super intensive for 24 hours, and then they're just fine. And they just bounce back and do great. So they're quite amazing. And I've had cases where I think this is a transient myocardial thickening. And then I see them 3 months down the line, 6 months down the line, and they're not. They're a cardiomyopathy with an HCM phenotype. And then I see cases that completely blindside me, that I think, it's a ragdoll cat. It's a 6-year-old ragdoll cat. I remember one guy, I think he's in the case series, who was a 6-year-old ragdoll, and he really looked like HCM. He had some systolic anterior motion. He's one of the classic breeds we think about for genetic, sarcomere-based HCM. And he went home, let's treat your cat's heart disease. And then he came back at 6 months for a routine re-examination. We hadn't even considered transient myocardial thickening. And there he was with a normal wall thickness and a normal left atrial size. And we just couldn't believe it. So really, they can blindside you. I think one of the big clues for me is very severe heart failure signs. As you say, a history of an antecedent event, often younger cats. But I think the troponins are often high, very high in those cases. So this is where cardiac biomarkers, they don't change my treatment, but they change how I think about a case. If I've got an acute, what looks like HCM phenotype with heart failure signs in a 2-year-old cat who's recently been anesthetized for a foreign body surgery, for example, we get a troponin of 20. The reference on most analyzers is less than 0.1. That would be a 200-fold elevation of troponin. That's massive. That would make me think, hang on, this isn't just a classic heart failure where we may get some elevation of troponin. This is an inflammatory condition, or something where we've got cell swelling, necrosis, something nasty going on. And I'd be thinking about myocarditis or transient myocardial thickening. So as you say, Jose, I would just give them a chance. I think talking about the treatment of heart failure, acute heart failure, chronic heart failure, refractory heart failure in cats is definitely a separate podcast topic, and one where we can certainly seek some opinions. I think what'd be nice to do is, obviously being a podcast, we have a social media presence. What we're going to do is probably tweet a couple of articles and share a couple of pictures of discrete upper septal thickening, just so we've got an idea of what that looks like in our head, and maybe a left atrial fractional shortening, just for any of you who haven't measured that before. You can get an idea of what that looks like when one of us takes those pictures and does those measurements. So I think it's probably time to wrap up our first topic in the animal heartbeats. Jose, do you want to say some final words, some take-home wisdom for anybody listening to this podcast?
So thanks again for listening to our first podcast. So feline cardiomyopathies, highly prevalent. Most common heart disease in cats. Difficult to diagnose because some cats would not have heart murmurs and still be affected by cardiomyopathy. When they do have heart murmurs, loud murmurs are more likely to be associated with cardiomyopathy, HCM. Older cats, male, are more likely to be affected. So keep that in mind. Biomarkers, NT-proBNP might be very useful to screen for heart disease and decide which cats are more likely to have this condition. Don't forget that there are many diseases out there that mimic HCM, so we need to exclude them, namely high blood pressure, hyperthyroidism. And there are some, and sometimes heart disease looks very nasty, and still cats respond very, very well to heart failure treatment. So just treat every cat you can, because sometimes it will be highly, highly rewarding. And feline cardiomyopathies are the best. That's what I wanted to say.
I think you've very beautifully, eloquently summed up the whole podcast in less than 1 minute. So that's I would agree completely with that. Fabulous. Thank you very much to everybody. Please follow at heartbeat_pod, and our Instagram is also heartbeat_pod. So we will be sharing some pictures of what we've talked about in the podcast, and obviously we'll be sharing details of future episodes there. Stay tuned in the future and follow us on Apple Podcasts or wherever you get your podcasts from, and you can subscribe and stay up to date. Thanks very much.
All right, thank you.